Then, about competitive inhibition, guys, do you know what is the competition between what? Between two things. Yeah, there is a big competition between substrate and inhibitor. And you can see here that when the inhibitor attached to enzyme, the substrate cannot attach to enzyme. Am I right? You can see here the substrate and the inhibitor attached to the same side of the enzyme. And they compete with each other to attach the active site. Guys, about competitive inhibition, I want to tell you about the changes that occurs in some items like Vmax and Km. Competitive inhibitors just have effect on affinity of enzyme to substrate and decrease the affinity of enzymes to substrates. With decreasing the affinity, what change we can see on Km? Increasing the K. If I ask you which of these choices affect by competitive inhibition, you should choose K. And about the increasing and decreasing, you should say that it increased. Another thing, in Lineweber plot, you can see that the y-intercept is constant, but in competitive inhibition, the Km increase. It is -1/Km that it is increased again. It was about competitive inhibition. What about non-competitive inhibition? What do you think about that? About the site that it attached to enzyme. What do you know?
It attaches to a site other than the active site of the enzyme.
Yes, exactly. Other than the active site of the enzyme. For example, this is your active site of enzyme. The inhibitor attached to another part. It can attach to enzyme alone or attach to enzyme substrate complex. No differences. Both of them inhibit the enzyme action. They aren't our students. Oh, I think I'm not here.
No, there are still some people.
Okay, good. These are about non-competitive inhibition, that the inhibitor site is different from active site. What do you think about the changing in Km or Vmax?
The Vmax is the same, but Km increases more.
No,
Decrease.
Km is the same. Why?
Because it doesn't bind like no side.
Yeah, because site of attachment of substrate to enzyme are different. The affinity of enzyme to substrate have no change. But the Vmax is decreased. Guys, in competitive inhibition, if we start to increase the substrate concentration, our Vmax will increase and we will have maximum velocity. Okay? But in non-competitive inhibition, we can't do that. It was about the explanation that I give you. And again, you can see here the curves about non-competitive inhibition. upside down. And I'll explain you about the covalent tree as well. Friend mentioned that another important thing as our future medical doctor, your country future medical doctor, you should know that more than half of the 10 prescribed drugs are worked by enzyme inhibition. I will give you some examples. At first, guys, have you ever heard about methanol poisoning? Methanol poisoning in Iran, because the ethanol consumption and alcohol consumption is illegal. And there are some illegal sources for providing the alcohol. And some of them just sell the methanol to people, and it will have, after that, bad effect, even dying. We have every... Yeah, do you know about the mechanism of that? Why it is poisoning? Why the methanol is poisonous, but the ethanol is not?
Why did you say that? Why do you use it?
They don't know that it is methanol. Just the seller have some cheating and give them methanol instead of ethanol because the price of that is lower and it's cost effective for the seller. But because of illegal issues, everything is continuing, and every year we have lots of people that are passed away because of methanol consumption, or in a better situation, they become blind. I want to tell you about them. I don't know what is happening in other countries, but it is a serious problem in our country. I want to tell you about ethanol metabolism and competitive inhibition. Guys, you can see here the ethanol metabolism. At first, when a person uses ethanol, ethanol converts to acetaldehyde by alcohol dehydrogenase, and after that, by another enzyme under the name aldehyde dehydrogenase, the acetaldehyde is converted to acetylene. And after that acetyl-CoA, it can actually metabolize in a safe way. I'm not speaking about the excessing of NADH, of overdosing of ethanol, but I'm just speaking in normal situation. It is the pathway that ethanol is metabolized. Okay, now I want to tell you about the methanol. What is happening to methanol? Those reactions occur in the liver. Okay, methanol, under the effect of alcohol, the hydrogenase convert to formaldehyde. Formaldehyde converts to formic acid by aldehyde dehydrogenase. Instead of acetyl-CoA, now we have formic acid. At first, it enters the blood circulation and produces metabolic acidosis. After that, it will go to the eyes and have retinal and optical nerve toxicity. Have retinal and optical nerve toxicity and cause blindness. And because of that acidosis that occurs, if they don't refer to the medical doctor and don't be honest about the thing that they consume, they will die. We have yearly a high statistics about these dying. Now I want to tell you, methanol is converting to formic acid by alcohol dehydrogenase and aldehyde dehydrogenase. Now, if we start to administrating ethanol to the patient, at first we should diagnose on time. Okay, we start to administrate ethanol orally or intravenously. Okay, in a special doses, or maybe some drug under the name fomepizole. What is happening? This enzyme is involved for ethanol or fomepizole metabolism and cannot have effect on methanol. In the result, the formic acid production is inhibited, and the methanol have chance and have time to excrete through kidneys and urinary tract without converting to formic acid. It is a competitive inhibition that we can see in ethanol and methanol metabolism, and it is the way we're curing these patients.
Are we supposed to know the whole pathway? Are we supposed to know this whole pathway? Like,
No, the whole pathway, no, because it is soon for you. You will study in the other stages and the other courses that you will. But you know that ethanol and formimazole, they are inhibitor of alcohol dehydrogenase. Okay? And now that they are competing for ethanol and methanol metabolism, just it's not about the substances that they are producing. Another drug, have you ever heard about statins? Atorvastatin, pravastatin. In some older, not older, adults, for example, more than 40 years old, it is so prevalent. What is happening? Because of high cholesterol level, they start to use the drug under the name statins. Statins inhibit the enzyme in cholesterol synthesis pathway under the name hydroxymethyl coenzyme R reductase. Good. I want to tell you an important issue about enzyme. Imagine this is the metabolism pathway. Okay. The most important enzyme is here. That are regulated by different ways, for example, phosphorylation and some other ways. This is the rate limiting steps. This process is called rate limiting steps, and generally the enzymes that act here are allosteric enzymes. Did you get the point? When the regulation wants occur in this step. And for example, here is the pathway of cholesterol synthesis by blocking the HMG-CoA reductase, the rate limiting step of cholesterol synthesis, the cholesterol synthesis is blocked. And we have no cholesterol, and we can control that. You can see here the HMG-CoA reductase active site, and this is HMG-CoA. HMG-CoA. And this is the structure of pravastatin. You can see that this structure is similar to here and can attach to active site. HMG-CoA in this situation cannot attach to enzyme, and we have no cholesterol synthesis. Okay? And now pravastatin is competitive inhibitor of HMG-CoA reductase. Did you get that one? Maybe I ask you that the mechanism action of statin for decreasing cholesterol is what? You should tell me competitive inhibition. Okay? And enzyme that helps to constriction of arteries and increasing blood pressure in physiologic situations. If a patient comes and have hypertension, the drugs like losartan, captopril, enalapril, and lisinopril is prescribed that inhibit an angiotensin converting enzyme in a competitive manner. What does it say? It says that the blood pressure increasing will inhibit it and the blood pressure decrease. It is used in hypertensive patients. Okay? And another thing is about these were competitive inhibition. Now I want to tell you about non-competitive inhibition. Have you ever heard about goat? Goat. In Iran, we have the people that they are so rich and they use a lot amount of red meat.
Goat animal. You mean goat animal?
No.
Yeah, red meat of animals.
Yeah.
Okay. After that, the amount of, because the red meat is full of, for example, from cow, from cow, from sheep, yeah. They have a lot of nucleotides, point and pyrimidine. Am I right? Because those meat product is full of the nucleotides, they metabolize and convert to uric acid. Okay? This uric acid can be normal in a level, but after increasing the high amount of red meat and increasing the uric acid level, it will convert to some precipitation of uric acid. What is happening? They will make some crystals and will precipitate in, for example, in thumb, in joints, in your finger, especially in the tongue. Yeah, in toes of our feet and legs, and they are so painful. Yeah, they swallow and they are so painful, and we call those crystals toffee. Toffee. On those situations, the drug that is prescribed for goat situation is allopurinol. Allopurinol converts to oxypurinol, and oxypurinol inhibits the enzyme xanthine oxidase. And the production of uric acid will be inhibited. Guys, you will study all of these mechanisms and pathways by detail in the next semester. Just I want you to know that allopurinol as a non-competitive inhibitor inhibits the xanthine oxidase enzyme. It is the important thing that you should know about the allopurinol and non-competitive inhibition of xanthine oxidase. Another thing, guys, do you know about aspirin? Or
Aspirin?
It's for fever. Fever.
Is it aspirin for?
it's anti-inflammatory drug.
Diabetes.
Yeah, it is anti-inflammatory drug. Yeah, and it is, guys, the effect of that is an enzyme under the name cyclooxygenase 1 and cyclooxygenase 2. Inhibit these enzymes irreversibly and decrease the effect of for example, some inflammation. Okay? You will study these pathways again next semester completely, inshallah. But now there is no need for memorizing them. Guys, now I want to tell you about enzyme regulation. That yesterday we discussed about all of them, just we are reviewing. At first, decrease. So, there should be a tight regulation in our body. Am I right? And these enzymes in these pathways can be regulated by allosteric regulations, covalent modification, and enzyme synthesis. They are rapid way for regulation, but it is a little slower than, because the synthesis have time from hours to days. I explained you that allosteric effectors bind to other side of the enzyme other than the active site. Am I right? This was related to allosteric sites and allosteric effectors that have effect on the enzyme. Here you can see the changes in velocity of enzymes with allosteric function. Another important thing that I want to tell you, the allosteric effectors can be homotropy, that we call them positive effectors, and can be heterotropy, negative effectors. Do you know what did I mean? What do I mean? For example, can you tell me an example of homotropy on hemoglobin, not the enzyme, that I told you yesterday? What is the homotropic effector for hemoglobin and what is heterotropic effector for hemoglobin?
Oxygen binds to the main group, so it makes it easier for the successive oxygen molecules to bind.
This is homotropic. And about heterotropy?
ATP production.
ATP production, but bisphosphoglycerate that I told you 2 and 3 BPG. It is a negative effector and heterotropic effector for hemoglobin. And this is correct about all allosteric enzymes too. Did you get the point? Yes?
Please explain heterotropy a bit more.
Heterotropy is an effector that at first binds to the other side of the enzyme and this decrease the enzyme activity and have negative effect on enzyme function. I told you yesterday that about the hemoglobin, oxygen increase the affinity of hemoglobin to other oxygen. But something under the name 2 and 3 BPG or bisphosphoglycerate decrease the affinity of hemoglobin to oxygen. It is great about allosteric enzymes too. Guys, I'll explain you about rate limiting step. Do you remember here? I'll erase that. Do you remember about rate limiting step that I told you about cholesterol synthesis? You can see here, guys, the product, when the amount of start to increase, the product inhibits the rate limiting step enzyme. Okay? This is the rate limiting step that all regulation occurs here. And generally, the pathway is one way, is reversible, not like this two-way. The rate limiting step is one way. And you can see here the effect of effect inhibition. Guys, it was related to allosteric effector. Do you have any question? Another situation is covalent modification that you can see. I've explained to you about phosphorylation. Am I right? On which amino acids? Phosphorylation on? Serine and threonine. Okay? You can see here that a protein under the name protein kinase, an enzyme, use ATP to phosphorylate enzyme. And on the other hand, another protein under the name phosphoprotein phosphatase starts to dissociating the phosphate and produce hydroxy enzymes. Guys, have a little rest and another will be attendance list, and after that continue finishing the session. At first, she was shaky, yeah? She has these. All of these alter and don't. Maybe they just express in a situation of our life. But no, in some physiologic condition, maybe we need different parts of enzyme. That I've give these examples for several times about increasing blood glucose level, the insulin level, and the key enzymes for synthesis insulin and for glucose metabolism after feeding start to increase. And the other point, as I've explained you, alteration in enzyme synthesis are slow, hours to days. But about covalent modification and allosteric effector, it occurs for seconds and minutes. But for synthesis, it is slower than the other two. Guys, the final thing that I want to tell you, the final subject, is about enzymes in clinical diagnosis. In clinical diagnosis, guys, we are using samples that are available, like which sample we are using in the laboratory for tests, diagnosis, blood, urine, stool. What about tissues and something like this? It is difficult. Yeah, for, especially for tuberculosis, and it is a practice. I don't like that. At first, it is so difficult, and after that, we start to get used to and we adapt to it.
Like most.
Right?
Like most.
Yeah, exactly. Exactly. These plasma enzymes, guys, have two situations. Some of them, the working of them should occur in plasma, like coagulation and related enzyme, the enzyme that have role in blood coagulation. They are in blood circulation. At first, they are inactive. Do you know what do we say to the inactive form of enzyme? Proenzyme? Pre-pro. That's not related to protein. It is not incorrect. Zymogen. Yeah. We at first tell them zymogens. They are inactive. Zymogens. They are inactive. After that, when we need them, they start to become active and convert to the lots of proteins, guys. Proteins in our intestine and pancreatic enzyme. Lots of proteases are released as zymogens and lots of blood coagulation enzymes. And some of other enzymes, they are not normally in blood circulation. For example, they origin from our heart muscle. They origin from our liver cells. Okay? During the normal turnover of our cells, they may be released to the blood circulation. In physiologic situation, we have our body, it have a, actually isn't static. Am I right? The cells are producing and destroying, The turnover is occur in our body. Okay? For example, our liver cells, our about muscle and nerve cells, no. Lots of our cells, skin cells, lots of our cells. During the turnover, a little enzyme may release to the blood circulation. It is normal. For example, I have lots of examples about ALT and AST. I told you that they are for evaluating liver function test. Am I right? Normally, we have a concentration, for example, less than 20 international unit or less than 40, near this amount. Less than 40 international units. Guys, in this normal in our blood circulation. This is our normal cell turnover. But if, for example, it starts to be 60 international units, it indicates that your liver cell is damaged. That's why the enzyme is released to the blood circulation. Did you get that one? This is related to liver enzyme. Another thing, guys, imagine we have an enzyme that works in all of our tissue and cells. Can we work on that enzyme for diagnosis? Yeah. Imagine, for example, I have an enzyme under the name, for example, cytochrome C oxidase. I have in my liver, in electron transportation, I have in muscle, I have in my kidneys, I have in my heart, I have in my all organs of our body. Can I use that enzyme as a marker for clinical diagnosis? Apparently not. Why? Because you should choose the markers that are specific for a specific situation. For example, you are saying that, okay, this, for example, ALP, alkaline phosphatase, is evaluating for liver, for bone, for different situations, different isoenzyme of them in there is. Or maybe about, guys, have you ever heard about PSA? Prostate specific antigen. We have a marker under the name prostate specific antigen. The men that are older than 50, 40 and 50, it is recommended that they have routine checkup of PSA. It indicates the hyperplasia of prostate. Okay? In this situation, it is a good marker. Why? Because it is specific for prostate, no other parts. Not about the urinary bladder and not about other parts. So I explained you about the plasma enzyme, and here I explain about international unit that it is the unit for reporting enzyme level. It is just for your information. It's extra information. Guys, I explained you about the normal turnover. You can see here, for example, not about liver cells, why it is a little difficult maybe, about your red blood cells. Okay? After 120 days, your red blood cells or RBCs start to destroy. Am I right? The thing that is inside the RBC can normally release to the blood circulation. In normal situation, we have a normal turnover. Some RBCs is producing and some of them is degrading. When there are pathologic situation, in this situation, the RBCs or other cell of interest start to become more destroyed, degrading. What is happening? The more enzyme is released in blood circulation, the more content of the cell is released to the blood circulation. And increased plasma level of that reveal the diagnosis and pathologic diagnosis. Did you get the point? This was related to the enzymes in clinical diagnosis. Guys, another thing that I don't put in my slide, but I think it is better to say, is about isoenzyme. Have you ever heard about them?
It's in your slide. It's in your slide.
Explain completely.
Pattern of isoenzymes found in the plasma nature for
differences between these isoenzymes we have different. Have you ever known about creatine kinase? I told you that creatine kinase convert. I'm rated in Persian. Do you know about these enzymes? I told you yesterday that creatine kinase is used for actually making your muscle more strong. They are the source of ATP in our muscle. We have different isoenzymes of CK. All of them are doing these reactions. But some amino acids are different, isoenzymes are different. We have CKBB, CKMM, and CKMB. CKBB is specific for brain, CKMM is specific for muscles, and CKMB is specific for heart muscle. What is happening? Because this enzyme is specific for heart muscle, when the level of that increase in blood circulation, it indicates that there is something happening in your heart. And especially the thing that is happening is MI, myocardial infarction. For example, a person comes to the clinic and have abnormal electrocardiogram. You should, abnormal electrocardiogram, you should evaluate the CKMB enzyme. If the level of that increase, it indicates and proves that you had myocardial, your patient had myocardial infarction. It was related to the isoenzymes that I told you. I explained about all of them, and here you can see, guys, the CKMB is just elevated in our blood circulation for 4 to 6 hours. After that, decrease and fall in normal. In the first steps of myocardial infarction, you can use that for clinical diagnosis. Thank God it finished on time. Guys, it was my pleasure. Again, I'm saying it was my pleasure to see you, and I hope everything will be okay for you. And if you have any problem in this island, okay, I have some friends that they are not here because they are studying in all other countries or maybe in other parts of Iraq. But if you have any question, for example, for buying something, for providing some general things, not a special medical thing, you can ask me and I can ask my friend and tell you if there was no one to help you, okay? And I hope everything be in the best way and best thing for you. And when you come to Iran, I will be happy and see you again. And another point, I just add one more other slide to these slides that I want to convert it to PDF and send to your classmate. Rabi Haydar, your aim is from here.
Yeah.
And no, it is so great, but I try to learn that, but I can't understand the thing that you are saying. Guys, the class is finished, and I hope that all of the things that we work on them be useful for you. Have a great weekend, have a great time, and take care of yourself and enjoy your time. خواهش میکنم. You are welcome, you are welcome. I asked you, I told you